Hello, I'm Dr.Jazeer once again, and welcome back to the discussion of INICET part 2. Now we are going to continue with the same discussion what we had done in the previous episode. So now let us see the questions again. The first question is, identify the type of lesion. So can you see this lesion? What does it look like? It looks like a ring, isn't it? Round lesion. And now look at the options now. The options are bullous, annular, urticarial and targetoid. So what do you think? It is a very simple question to be asked in INICET, because option number A, bullous, means it is going to be a vesicle that is more than 1 centimeter in diameter. So it is definitely not a bulla. The second is annular lesion. So annular means a ring like type of a lesion. So the correct answer is going to be annular. So the third option was urticarial. So urticarial means the lesion is going to have something like this, where there is going to be an edema beneath the skin. And what is targetoid lesion? Target lesions and all you see in a condition called as erythema multiforme, that is usually seen with certain infections like HSV, and also it can be seen with some drugs as a side effect. Okay, so these are all the options, and the answer for this question, the answer is annular. So now let's see the next question, that is, which organism causes the most painful genital lesion? So the options are LGV, syphilis, herpes simplex and Shankroid. So these are the 4 options that is given. So what do you think? For getting this MCQ right, you can easily remember a mnemonic. Like the mnemonic is like this. So painless genital ulcer. So painless genital ulcer, you can remember it with the mnemonic LSD. So what is LSD? LSD is a drug, and if you take a drug, you may not get to know about the pain, isn't it? So remember, LSD stands for painless genital ulcer. So L stands for LGV, S stands for syphilis and D stands for donovenosis. So all these are the 3 examples where there is not going to be any pain for the ulcers. Whereas painful genital ulcers, there are 2 examples, the remaining ones. So what are the remaining ones? That is the Shankroid and the herpes genitalis called as HSV. So now in this question they asked which organism causes the most painful genital lesion. So if I said that there are 2 options, one is Shankroid and the other is herpes genitalis. So what are the causative organisms? The options are given in C and D. So multiple answers are correct, that is HSV or herpes genitalis and Haemophilus ducreyi for Shankroid. So that is the right answer for this question. So now let's go to the next question. So the question says true regarding Shankroid. Again it is the same topic. So true regarding Shankroid, the options are it bleeds to touch, painful ulcers, groove sign is seen and school of fish appearance. So Shankroid, as you know, earlier we discussed that Shankroid causes painful genital ulcers. So option number B is correct. Now the second thing, now let us go option by option. The first option, that is bleeds on touch. So which is that genital ulcer that bleeds to touch? The answer is beefy red ulcer that bleeds to touch is seen in donovenosis, not in Shankroid. So option number A is not correct. Option number B, that is painful ulcer, is a correct option. Now let's see the next one, groove sign. So where do you find groove sign in genital ulcers? Groove sign of Greenblatt, if you remember, that is seen in a condition called as LGV, okay, lymphogranuloma venerum. And whereas pseudo groove sign of Greenblatt is seen in donovenosis. So groove sign is also not the right answer. So the fourth option, that is school of fish appearance. Of course, yes, railroad track appearance or school of fish appearance is characteristic for Shankroid. So the right answer here would be option B and D, that is painful ulcer and school of fish appearance. So now let's go to the next one. Subepidermal blisters with neutrophils. What is the treatment of choice? So the question says it is a bullous disease or a blistering disease. And where is the blister? Is it within the epidermis or beneath the epidermis? The question says subepidermal blister. So subepidermal blisters with neutrophils. So which disease comes to your mind when you say subepidermal blister with neutrophils? So the first thing that comes to your mind would be dermatitis herpetiformis, isn't it? So in dermatitis herpetiformis, you are going to get a subepidermal blister. Papillovesicles are seen in the extensor parts of the body, and another disease that comes to your mind would be the linear IgA disease. Okay, so in both these cases, you will be able to see neutrophils beneath the epidermis as well. So, be it dermatitis herpetiformis or linear IgA disease, what is the drug of choice? So, you just see the options: dapsone, cyclosporin, azathioprine and rituximab. The answer is dapsone, because dapsone is a drug of choice in both these conditions. So, now let us go to the next question. Patient suffering from chronic plaque psoriasis with 50% body surface area involved, which of the following is not used in the treatment? Now we are going to discuss about psoriasis, and in psoriasis, in the question says more than 50% of the body surface area is involved, and what is not used in the treatment. So treatment of psoriasis we have discussed many times, because we know that in the treatment of psoriasis we have many topical agents. So topical steroids are used, okay, topical calcineurin inhibitors are used, and topical retinoids are used. So many vitamin D analogs are used. So all these topical agents are there, but topical agents are preferred when the body surface area involvement is less than 10%. Okay, now more than 10% body surface area is involved in psoriasis, we would be going for some phototherapy, and if phototherapy does not work, we will be going for some systemic agents like methotrexate, cyclosporin, azathioprine, etc. And once all these fails, we will be going to the biological agents. So these biological agents, they involve all these TNF alpha inhibitors, so all these ustekinumab, secukinumab, adalimumab, all these etanercept. So all these things are used as the biological agents in the treatment of psoriasis. Now let us see the options. So which is not used? So NB-UVB, that is narrowband UVB, is option A, cyclosporin is option B, C is coal tar, and D is prednisolone. So option A, narrowband UVB, is of course used, cyclosporin is of course used as a systemic agent, coal tar is used topically as a topical agent, and what is not used among all these options is prednisolone. Why prednisolone is not used? It is because if you use oral steroids or prednisolone in the cases of chronic stable plaque psoriasis, it can lead to another type of a psoriasis which is called as acute generalized pustular psoriasis. So this is also called as the von Zombusch reaction. So to avoid such a generalized pustular eruption, it is always preferred that systemic steroids, that is oral steroids, should be avoided in psoriasis. So the odd one out here is prednisolone, option number D. Now let us go to the next question. The histopathology is suggestive of. So an image is given like this, and the histopathology is suggestive of which disease? Is it psoriasis, leishmaniasis, mycosis fungoides, or pemphigus vulgaris? Now closely see this image. You are able to see a split of the epidermis. So can you appreciate that there is a split in the epidermis, and if you look closely, where is the split happening? The split is happening at a layer just above the stratum basale. So suprabasal split of the epidermis is seen in a disease called as, is it pemphigus vulgaris or is it pemphigus foliaceus? The answer is pemphigus vulgaris, which is given in the option. So if the question would have been pemphigus foliaceus, you would have seen a subcorneal split, not a suprabasal split. So you must be remembering the sites of split in all these bullous diseases. Okay. So now let's go to the next question. So the next question is, a 23-year-old patient comes with a complaint of a non-scarring alopecia, and this alopecia is in the vertex of the head. Histological examination shows there is a loss of hair with hemorrhage into the follicular areas and mild perinuclear lymphocytic infiltrate. Now, what is the diagnosis? The options are alopecia areata, telogen effluvium, tinea infection, and trichotillomania. So what do you think? once you get to know it is a young patient, 23 years old, it is a non-scarring type of an alopecia and it is localized to the vertex of the head. And histology, it shows hemorrhage as well as lymphocytic infiltrate. So you may be confused between alopecia areata and trichotillomania in this case. Because why? In telogen effluvium, you will be having a generalized hair loss. Okay, here the hair loss is more in the vertex area. The second thing is between alopecia areata and trichotillomania. What happens? Both can present to you as a patchy hair loss, both can present to you as a non-scarring alopecia, both may show you some lymphocytic infiltrates as well. But see the age of the patient, 23 years old, and see that you can see some hemorrhage into the follicular area. A hemorrhage within the follicular area means the patient must have tried to pull off the hair by himself or herself. So that is the reason. So if somebody is trying to pull out the hair by himself, this is called as a condition which is considered to be a psychiatric illness as well, and this is a condition called as trichotillomania. So the right answer here would be trichotillomania. Now let's go for the last question, that is lesions and changes on the anterior shin are least likely to be seen in. So options are sarcoidosis, diabetes, hyperthyroidism and hypothyroidism. So what do you think is the right answer? Anterior part of the shin, in which of these conditions you are not expecting a skin lesion? Okay, so let's go case by case. The first one, sarcoidosis. In sarcoidosis, you will be able to see a condition called as erythema nodosum, which is a type of a septal paniculitis that is seen in sarcoidosis. So sarcoidosis can be ruled out. The second one is diabetes. Do you find any skin lesions in diabetes in the anterior part of the shin? Of course, yes. You will be able to see some atrophic lesions as well. Also, you can see some necrobiosis lipoidica diabeticorum. So these are the typical skin lesions that you see in diabetes. The third one is hyperthyroidism. What do you see in hyperthyroidism? In hyperthyroidism, you will be able to see a condition called as pretibial myxedema. So pretibial myxedema is typical for a hyperthyroid patient. So in which condition do you not see any skin lesions in the anterior part of the shin? The answer would be the last one, that is option D, that is hypothyroidism. So with these discussions, let us wind up this series of discussion of the INICET questions. I shall come up with one more episode, probably 2 more episodes where we will be discussing more questions from all the recent papers. Okay, thank you for watching.